Okay, hello again. It is time for Unit 8. So this unit covers a lot of territory. Starting with the eye, we're going to talk mostly about glaucoma. And then we're going to come back and talk about the skin, mostly about acne. And then we're going to do a series of videos on the anti-infective agents and then the anti-neoplastic agents. So this particular video is going to focus specifically on an introduction to the eye and how that glaucoma is related to the eye, or what happens in the eye in relationship to glaucoma. So here's a picture of the eye, as I'm sure you've all seen from anatomy. If you remember, there's 3 layers. The middle layer is the layer where all the blood vessels are. The inner layer is where the photoreceptors are, the retina, and the outer layer is where the sclera of your eye, the white part of your eye, and also the cornea is. So in this picture, what I want to point out to you is the cornea, which I know you guys know where that is, but that's this front part. So this would be anterior, of course, this is posterior. Here's the optic nerve, which is something that we're going to be talking a little bit about. This right here is the lens. So as I'm sure you remember, the eye is divided into 2 chambers, a front chamber called the anterior chamber, the back chamber called the posterior chamber. It's full of fluid. The chamber in the back is full of a sort of a gelatinous-like fluid called vitreous humor, which rounds out the eye and actually also holds the retina in place. And the front of the eye, the fluid that's produced in the middle layer, the muscular portion of the middle layer, which is called the ciliary body, that's where the fluid is produced. The fluid that's produced at the ciliary body, some of it drains through the pupil, this hole, and it fills out the anterior chamber. And in the anterior chamber, we call that fluid the aqueous humor. So that fluid, so this is a different view, right? Excuse me, here's the ciliary body. This right here is the iris of your eye, the colored part of your eye, which is just really made out of smooth muscle fibers. This is the lens in this view. So the aqueous humor is produced here, and it's going to kind of squeeze through the pupil between the lens and the iris and through the pupil, and it's going to come out here and it's going to fill in this anterior chamber. That's where all the nutrients for the cornea, which is not vascular, so it doesn't have any blood supply to the cornea, so it gets its nutrients from this fluid in here. And then it comes over here and it drains through this, there's like a kind of like a mesh here called the trabecular meshwork. And it drains, the fluid drains, kind of has to go through this trabecular meshwork, which is sort of like a sieve, and then through the canal of Schlemm right here, and then it goes from there into the venous system. So our conversation is going to be around glaucoma, which is an increase in the pressure in the eye, and where the pressure comes from in the eye is the fluid. So really what's happening with glaucoma is either we're making too much fluid or it's not draining adequately. But in either case, the fluid production and the fluid drainage in a normal eye would be equivalent. So the pressure stays steady. The pressure in the eye is measured in millimeters of mercury, and normal pressure, intraocular pressure, is like 15 to 16, with some outliers on either end of that. When the pressure gets above 20 or 21, that's when we start really worrying about it. Here's another angle. I put a lot of pictures. I couldn't decide which ones I liked the best, so I just put them all in here. So this is showing us, again, kind of from a different view, but this is showing us where the fluid is made, and then this is the fluid path from the posterior chamber to the anterior chamber. So you can see it coming through the pupil here and then going out through this trabecular meshwork and then through the canal of Schlemm. So that's how it goes. So if you have glaucoma, what happens is the fluid can't drain, right? It's either because it's being made too fast or it's not draining fast enough. Either way, the pressure builds up. So the pressure in the eye builds up. And that can be detected. There's devices that read the pressure in the eye. I'm sure you've all experienced that certain form of torture, if you ask me, where they puff that horrible puff of air at your eyeball. Anyway, they're testing for a rebound, essentially, or measuring the pressure. So if the pressure builds up in there, the reason why it's a big deal is because ultimately what it does is it does damage to the inner portion of the eye, and where it really does damage is to the optic nerve. So that's the biggest worry. Glaucoma is pretty common. And it causes, in terms of symptoms, it causes peripheral vision loss, and it can actually cause blindness. So it's kind of a big deal, and it's common, and especially in elderly people. I can't remember off the top of my head what the statistic on glaucoma is, but it affects a fair number of people. I want to say 40 million in the US, but I think that's high. Maybe it's 4 million. I'll have to check. Oh, this is another picture. I just liked both of these so much I couldn't decide. Showing you again the damage to the optic nerve there. All right, so essentially what we want to do first is run through the types of glaucoma. There's 3 major types, and then we'll kind of get into basic treatment. So the first would be a congenital glaucoma, and that would be something that you would be born with, and that would require surgery. And there's different surgical options. They can go in there and they can take out the trabecular meshwork. They can do laser adjustments. They can do all kinds of stuff in there for surgery. But we're not talking about surgery because we're talking about drugs, and you don't treat congenital glaucoma with drugs. So we're not going to talk anymore about that. So the 2 main types of glaucoma we refer to as primary glaucoma. The first is called narrow angle, or as I like to call it, your book calls it narrow angle, also called closed angle. That makes more sense to me. When I show you pictures, I'll explain to you why it's called closed. Also, sometimes it's called acute congestive. So all of these different sort of terms are helpful in various ways. So essentially, in a nutshell, what's happening with narrow angle glaucoma is there's poor drainage because of the position of the iris. So the iris has been displaced and it's blocking the canal of Schlemm. So the canal of Schlemm is closed. That's where the closed angle comes in. So if you can't drain, what's going to end up happening is the pressure is going to build in the back, and it's kind of going to push the iris kind of over even more, and it's going to close the angle between the cornea and the iris. So this is not the most common kind. It's actually the least common kind. Only about 5% of people with glaucoma have this type of glaucoma. It's more common after trauma. It's also common after if you have like a sudden pupil dilation, like for example, if you were at the movies and you came out during the day and it was really bright and you were prone towards glaucoma and your eye pupil dilated, that could displace your iris. Some medications can cause narrow angle glaucoma as well. So the main treatment for this particular type of glaucoma are pupil constrictors, because what that's going to do is it's going to pull the iris away from the canal of Schlemm if you constrict the pupil. And this, I can't remember if I just said this, but I don't think I did. This tends to be acute, like I said, so it comes on pretty quickly. And it can also, sorry, I couldn't remember what I wanted to say. It's usually unilateral, meaning it's only on one side, not both. All right, and if somebody continues to have issue with narrow angle glaucoma, sometimes they might have to do surgery. All right, the most common type of glaucoma is called wide angle or open angle or chronic simple. Chronic simple doesn't really make a lot of sense to me, except for it's a chronic condition. So what's happening here is this is a drainage issue. And it's not because the iris is there, it's because the trabecular meshwork starts to deteriorate. And it's most likely a vascular issue, so it's probably due to abnormal blood vessel permeability, where it's quite common. Wide angle glaucoma is common in diabetics, it's common in people that have high blood pressure. People who are more likely to have vascular disease. So about 95 or 96% of people who have glaucoma have this type of glaucoma. This is a chronic condition because the canal of Schlemm is not totally closed. It's still draining. It's just draining slowly. So the fluid starts to build up slowly over time. So the intraocular pressure slowly goes up over time. Because it's a vascular disorder, it's oftentimes on both sides, so it's bilateral. They're going to probably need continuous drug therapy. And you might use some pupil constriction, because pupil constriction is always going to help the drainage, but it's not going to be as profound it's not going to help as much as what we talked about with narrow angle glaucoma. Most of the drugs that are used, especially the drugs of choice, the 2 main ones, are going to target the fluid formation. So they're going to decrease fluid formation. There's one other option for glaucoma, and that is secondary to some other issue, and it can be an infection or it could just be inflammation of the eye. Anything that could potentially get in the way of the drainage. So if someone has an infection in their eye where they've got a bunch of red, white blood cells and, inflammatory mediators and fluid in there just because of the inflammation, whether it's infection or inflammation, that can block the drainage as well. So in this case, what you would do is you would figure out what the problem is. If it's inflammation or infection, go at it from that angle, give them an anti-inflammatory. If it's inflammation, give them an anti-infective. If it's infection and / inflammation, and generally that will make the glaucoma resolve. So we'll finish talking about that. All right, so here's a couple pictures I wanted to show you. So this is normal, and again, that's what we're looking at here. This is the ciliary body, right? This is the lens, this is the fluid pathway, right? So it normally is produced and then it drains through the canal of Schlemm. Yay, that's how we want it to work. This one down here is our open angle glaucoma. This is the chronic one, right? Yes, this is the chronic one. This, or the wide angle. And see this angle right here? This is what we're talking about when we're talking about wide versus narrow. I have another picture of this in a minute. So it's draining, it's just not draining as well. So you can see the arrow. So the fluid's building up mostly in the anterior chamber. It can build up in both. And then this is the closed angle, so the fluid's not going to build up. The fluid, is not going to drain at all. So the fluid's going to go up a lot faster. These people are going to have symptoms like eye pain, maybe bulging eyes, headaches, facial pain, those kinds of things. Not so much here. These people are usually asymptomatic because the fluid builds up so slowly. Here's another picture. I couldn't decide, like I said. So this I like this one because it shows us the angle. So this is what we're talking about, open angle versus closed angle. Right here. So there's not as much space. So it's like like this as opposed to this. So again, this is the one that's chronic. Here's the closed angle one. Not draining at all, right? The iris is pushed off in the way. It's not able to drain. That's closed angle or narrow angle. Here's normal versus open angle or wide angle. So again, you see this here. So it is draining, but it's just not draining as well. This is an actual what it looks like under a microscope. This would be the cornea. This is the iris. This is the ciliary body. So look at this angle. Wide angle, big mouth versus narrow angle, small mouth. So that's the idea. This is what happens when you've got an infection or an inflammation. Either way, we don't know yet. We don't know if there's a lot of red blood cells in here, but it could be either or. My guess with that would probably be infection, but we're not sure. All right, so in the next video, we're going to talk about the individual drugs. But before we do that, I want to just tell you what the two mechanisms of action, the main mechanisms of action. So again, we're talking about glaucoma, and we are thinking about fluid and trying to get it out of there somehow, or stop producing it as much. So those are our two main mechanisms. Increase the outflow of aqueous humor from the canal of Schlemm, or the drugs of choice are going to decrease the formation of aqueous humor at the ciliary body. And we're going to revisit our autonomic nervous system drugs because we've been talking about pupil constricting and pupil dilating, and as of course we know, the control of the pupil is under the pupil is under the control of the autonomic nervous system. So we're going to come back and break these things down and individually, and I will see you in a minute.